Welcome back, and we're moving now into our third segment for the morning. Belize Medical Associates COVID-19 adjustments. There'll be some adjustments, and we've got the folks in to tell us all about it. Dr. Victor Rosado is in, along with Dr. Marcelo Coyi, both on the management there at Belize Medical Associates. Guys, good morning, and welcome.
Good morning, John. Good morning, Marlene.
Socially distancing ourselves from you guys, which of course is the way to go. So folks have been seeing the press release, and they're, the question came up as to why. I mean, people really respect and love the services of BMA. So let's get there and talk about the COVID-19 adjustments. What are these adjustments that we're talking about here?
Well, John and Marlene, Belize Medical Associates has a 30-year history of a reputable history of serving the Belizean public, and nothing has changed.
Yes.
We started preparing for COVID-19 from mid-January. I think in the end of January, I did a Facebook Live, which is something that we do often, in which I predicted that what Wuhan, China was doing at that time would only have bought us a few weeks to prepare. And so at Belize Medical Associates, from the end of January, we've been meeting with our staff. We've adapted, we've changed certain policies in terms of how we provide our service. We've had weekly meetings. Obviously, things came to a crescendo when we had the first official positive case in our country. And we had to make a decision, a bold decision nonetheless. But since yesterday, we've seen that two other private entities have also come up with their decision, and they can obviously speak for themselves. Our decision is basically us being honest to our people and honest to our staff. We have to acknowledge the architectural design of our hospital. We are not we have a certain footprint that we cannot expand. I think the country has seen that Carl Hughes now, which has a footprint of probably 10 times the size of
You mean like how spread
how
the
spread
is.
you are,
Yeah.
exactly. So Carl Hughes now had concerns. And so if Carl Hughes now, which is 10 times the footprint of Belize Medical Associates, had concern, well then obviously you can acknowledge that we have concerns in terms of how are we going to separate corona patients from non-corona patients. And so we had to come to that decision. We met with our staff. We are responsible for the well-being of our staff and also for the well-being of non-corona patients. And so we had to take that decision.
You said it was a tough decision.
Of course.
Let me hear, and I think that's part of what I'd like to understand. You're looking at a global pandemic, and it's kind of everybody is helping out each other just by staying home. That's how we help each other. So tell me a bit about how you weighed your pros and cons about this being the best fit position for medical associates.
Well, I think it's obvious. I think the ministry and the NHI authorities came to give guidelines. For example, in our NHI clinic on Regent Street, they said you have to put a physical barrier and you have to have two clinics. One for your respiratory clinic and one for the others. And we were able to do it there because we have a L-shaped clinic. So we just
So you had a
divide
separate
it into two.
entrance.
And so the maternal and child health clinics that were in one of the L's, we close it down. We just move it to the other side. So it's physically possible. So they have their own entrance now on Regent Street, separate entrance. Two entrances. BMA floor plan doesn't allow for that. We have one entrance, and everybody comes in, everybody commingles, everybody there with each other. And so I think if we continue to do that, we in fact may be contributing to more infections. So we want to say, no, we can't be part of that, we have to be part of the solution. And the solution is that we separate the two, but we have nowhere else to put the COVID patients. So that's why I say, even though we want to look at everybody, we want to take care of everybody, if we do that, we're going to, one person come in that's sick and get Everybody is sick.
Yeah.
So we don't want to contribute. In fact, we are actually want to adhere to this principle, this public health principle of separating the two. And so that was the only decision that we can take.
And that's
I think it works out well for us because I remember asking on Friday, we had a meeting with the DHS and other health officials, and I said, when are you going to open a respiratory clinic? And they said, Monday they will make that decision, and it's going to be Cleopatra White. I said, well, when is it going to be implemented? Well, you know, there is decision has to be made, but they think by tomorrow, Thursday, they will have a sole respiratory clinic there.
Yeah.
So that is why we juggle with the time and say it's not with immediate effect. It's when on Thursday when other things should have fallen into place.
Yeah. And you know what you're saying with a respiratory clinic is kind of what most clinics are doing right now, where you separate people who have the flu-like symptoms,
Physically.
possibly COVID, possibly flu or cold, but you have them in one entrance and one space versus the rest. And that's what you're saying. It just isn't possible
It's not
for you
impossible.
to be able to execute that at your hospital.
Precisely.
And the conversation, I think, has been a lot about the public health system. And we really haven't included the private as much in terms of what you can or want to do in the face of the pandemic. But your release also states that you are open to dialogue in terms of being able to offer the non-COVID related illness treatment to Belizeans. Explain that for me.
Well, Marlene, what will occur is you will still have babies being delivered, born.
Yes.
You will still have a child with a broken arm.
Yep.
You will still have an acute appendicitis, which are non-COVID cases. And so we need to be realistic. We need to divide our services so that we can be functional for a longer period of time.
Of course.
We talk about over information, and we are seeing on the television first world countries, their health systems are being tested to the limits.
Yeah.
And so we need to be smart. We cannot be too emotional. We need to be objective. We need to be guided by the science. That Belize Medical Associates can function, and other private entities can function in certain specific areas. So let's say we become the maternity wing for Belize City and for greater areas of the country. We can do diagnostics, that sort of thing. So try to separate non-infectious COVID patients from COVID patients so that we could weather the storm for a longer period of time. If we all start seeing and hospitalization, one thing is the clinic, the other thing is hospitalization. Hospitalization brings another issue in terms of PPEs, right? For one patient,
The protective gear.
Yes.
exactly,
Yeah.
the protective gear. For one patient being hospitalized, you need 8 to 10 sets of PPEs
Per day.
per day.
Wow.
Yeah.
And there's
And nowhere have
there's
people
no
been
way,
able to keep up with the demand.
and there's no way
No,
we
we're talking about the proper nut mask. We're talking
No, I mean,
I
even in
the
other
bunny
countries.
suit and the
Yeah.
and the mask and the goggles.
The
And
gowns, the
there's
foot.
nowhere we can buy that as a private entity at the
Yeah.
moment. The government has, we have heard, a certain supply.
Yeah.
And so I think the small amount that we have, we could donate to that stockpile. But really, like I said, we took a hard decision.
Yeah.
And I think our decision is us being honest to the public that we serve, and honest and responsible to our staff as well.
Yeah. What's been the reception so far?
It's been mixed. Well, looking at our, I think we also put it on Facebook. That's the only feedback I get, no? I think about 2/3 are happy with it. There's a third that say we're abandoning our patients, you know, and they are upset. And I understand that.
People are fearful.
You know, that how come I come to you all the time and suddenly you
Yeah.
can't come?
You can't.
But I think we have to understand the reasoning behind it, actually to protect the patients.
Yes, yes.
So that we can say, of course, we still will do the same what we have been doing now. We're gonna, if you have been traveling away, we're gonna put a mask on you, wash your hands. We are keeping the 6 feet. If you notice in my office now, my patient's chair is, not only did they, but I put the tape because automatically patient come in and take the chair and
pull it
to me.
Yeah.
But now with that mark there, they realize it.
Yeah.
And then now, as I was telling Dr. Victor, it's having the reverse thing because I said, Doc, I'm glad idea because suppose you infected. You will protect me too, so we protect each other.
Of course.
You know?
But there's also a cost implication here because if you would imagine someone who would be admitted, I mean, we're seeing 2, 4, 6, 8 weeks of treatment for one person in other parts of the world for the severe pneumonia-like illness that people get. So even if, had you been open, that would have been a very high cost per patient, wouldn't it?
Well, not only that, but the resources are not there. As Dr. Vic said, we have a limited amount of, you see, our protective equipment we have it more for the other infectious patients that come in. People may come with open tuberculosis, meningitis. We need to protect our staff, like for a few days. It doesn't take much resources to do that, so we plan for that.
Okay.
But to plan for a sustained epidemic, we're going to run out.
First day.
Yeah. But you know what, doctors? So BME, we're not accepting any COVID-19 patients. But people will come there with the flu. People will. How do we differentiate?
Well,
that is why we are saying we continue with the same procedures. Everybody gets a mask, who has a fever, who has a cough, is the doctor. If they do not fit in the pattern, we put them into a room. We have an isolation room. They're fast-tracked and seen quickly. That is the call of the doctor then. Because, obviously if you come with an asthma, it's easy to say, you can stay here and we can take care of you.
So we will definitely not turn back anybody if that is your concern. We have to examine our patients. We have to take a proper history. If somebody is in risk of imminent respiratory failure, we will provide oxygen, we will intubate, we will put in an isolation room. But we had to be honest with the public that we are not properly prepared to manage a full case of ICU and 10 days in a hospital. That basically is our statement. But we will definitely not close the door to anybody who comes in with respiratory symptoms.
What's been the traffic so far? I mean, we've kind of been on edge for a while.
The traffic has decreased by at least about 60% each day. Yeah.
Really?
Do you think people are just fearful of going to the
hospital?
clinic?
It's a combination of that, and I think the resources, the financial resources. I don't know which one it is, but I was telling we put a 3-foot marker between patients. Our chairs can take like this, no? We put a space here. Do not sit here, no? So I force you to. We haven't been able to enforce it because there's so much chairs. We get one per chair now.
Well, because the public health message right now is only go if you absolutely need to.
So we've also done suspended elective cases. So our message to the public that if you have a routine case, the doc will extend his prenatal visits. We're doing a lot more phone calls and WhatsApp consultations. So where before probably we were swamped with that, now we're even more, but now we are facilitating more. Our pharmacy does WhatsApp prescriptions and we use frontline express delivery to try and minimize person-to-person contact. So we've tried to be responsible. We've tried to adapt like most other institutions.
I think what's good though is especially for the at-risk, the vulnerable populations, an elderly person who wants to check in on their hypertension.
We don't want to. The last thing we want to do is to close our doors.
Yeah.
And that is something that we had to wait. That if half of our staff get infected with 2 patients, we will definitely have to close our doors. And so we want to stay open as long as possible so that we can serve our public. So when your grandmother falls down and breaks her hip, then we're able to do the surgery.
Yeah.
Or if your child has a fever, we're able to stay open and attend to them.
Yeah.
And if they're delivering,
And if there's a
We're able to
delivery,
take care.
we're able to do that as well.
And what about costs? I mean, are there any
Of course,
considerations being made?
At the moment-
we
parents-
have not gotten into that, but as a private institution, we do have to look at the economic implications of this crisis. We have a employee number. We have 123 employees, so we have to look after payroll. We have to be responsible with them. In terms of offering to the public, like I said, in how we are adapting,
Yeah.
but primarily our responsibility is to try and stay open.
Yeah.
Obviously, if you come in, like I said, we would definitely not turn away anybody based on your ability to pay.
Yeah.
All right.
So that's one of the things you said that's yet to be defined, because we see, I mean, this is a learn as we go process.
Of course.
It's a
Yeah.
once in a lifetime experience that we're all going through together. Your decision, as you clearly said, is based on your very honest assessment on how you can keep everyone safe under the current circumstances, and that you can still serve a population safely without putting them at risk
That's correct.
for any possible transmission of the virus. What else would you say that BMA plans to do during this time? We are so reliant on health education, health advice, and our health professionals to guide us along the way, because there is an overwhelming amount of information, but interpreting it is really what's most important.
Right.
Yeah?
yes. Well, we do it one-to-one with our patients.
Yeah.
You know, so that we begin at that point now. We do it education to our staff also.
Okay.
You know, because the staff are just as frightened as everybody
Of
else. You know.
course, yeah.
So we are implementing the universal precautions that I see you have done here. You know, we have put a line, for example, in front of the cashier, 6 feet away, and you know, as Dr. Vic was saying the first
Excellent.
day, everybody not the fool with that. But when you explain it to them, at least to protect you, you know,
Yes, yes.
hurry, go back, and
Of
you know,
course.
so it's where it's now catching on.
Yeah.
So people are learning that social distancing is the main tool that's going to be used.
Yeah.
You know,
Yeah.
and we wish we would do more of that. You know, and because we hope that we don't have that, you know, high peak. You know, we hope that Calvision doesn't get overwhelmed, because if that happens, we're in real trouble. We're in real trouble, because my understanding is that they have 10 ventilators, which they have for the usual intensive care unit patients. So it's not really that those are not COVID-19 ventilators. Those
Yeah.
are,
Yeah.
and they are getting some more.
They've
you know.
ordered some, yes.
But who is delivering at this time?
Well, it's not only that. I think we just have to be honest about the situation. Nowhere has been able to cope with mass. I mean, even very developed healthcare systems
Yeah.
have not been able to cope with if the virus spreads very quickly. So we stop that by stop moving and by doing all the preventative measures. How about things with the children especially? And I think we had a conversation this morning with CARFA, and Dr. St. John very clearly pointed out that the young people have been affected of recent, because there's this misinformation that children and young people aren't affected, but they can be.
Well, that's the teen and young adult population
Yeah.
who seem defiant in the U.S. population to all the stay-at-home measures.
Yeah.
I think in the population that in pediatrics in Belize, where we see more the under 12, the silver lining still seems to hold that
Yeah.
they are the least affected population. However, we still need to look out for them. Asthmatics, their airways are smaller than an adult airway, and so the possibility of it being obstructed is higher. So
it would be your asthmatics, your
Asthmatics.
juvenile diabetics, right?
fortunately, we don't have a lot of those. We
Yeah.
have much more adults who are diabetic and hypertensive and chronic obstructive pulmonary disease and that sort of thing. So the focus still has to be on the adult high-risk population, over 60, and people who have underlying medical conditions. But I think coming back to your original question in terms of what else have we done is about 2 weeks ago, we put on our Facebook page that our doctors are open to Facebook questions, and Dr. Coyi was hesitant and told me, don't put that, we'll be flooded with questions. And really, we've had a few questions.
Oh, really?
Yeah, so my message is that we're open, but let's try to be positive. Let's try to stick to the science. When it comes to negativity, I think that we're being drawn towards vilifying certain sectors of the population, vilifying a race, or what has happened with the index case. That has implications, because if we don't control that, then what will happen is that people will be fearful of getting tested. All right?
Yeah.
So being negative on social media and that herd mentality of let's try and find a boogeyman and blame everything on that person.
Pointing fingers, yes.
Really, that has.
And I think that first case brought it up very clear that we are putting a negative to being a positive patient. You know, which is.
And it's
we hope it does not
because
happen, you know, because we want to protect these people also. Because we want them to come out to get treatment very early.
People to get tested,
to
call and say they have symptoms or they suspect they have symptoms. And to be clear, you know, I think the message throughout has always been that it was imminent. The virus has spread almost everywhere. It was not that we were ever going to be 100% safe of not having the introduction of the virus. But what we can do now is lessen the spread.
Right.
Yeah. Have you been seeing good practices though? I mean, you guys are in front. You know patients more than anyone else. When you tell someone to do something, you know, they don't take medication to time. They may not do the exercise you tell them to do, change the diet that you tell them to do. From your experience, what are you seeing?
Well, the psychology of people comes into play in times of crisis. I think we need to be responsible as a people. Like I said, don't look for a boogeyman, but we need to be responsible for our personal actions. We saw when we said we were going to close the border at Saturday at 12, a herd of people running to Chetumal to do last-minute buying. So that sort of thing, that's our actions, and we need to take responsibility for that. That put our population at risk, it put our customs officers or immigration officers at risk.
Even our
that sort of thing. So I think we all need to step back and reflect on our actions. Stay at home if you are not providing an essential service at this time. I think Dr. Perez did an excellent presentation yesterday where he tried to explain the social distancing so that it's not holiday we're providing for our kids. We're trying to spread the transmissibility of the virus so that if I have it, so we need to look in the context of our reality. We didn't have thousands and thousands of tests. And we always knew that we probably had it already, but we were late in testing it. Why? Because we didn't have enough tests. So if we have it, and if we have a sore throat, and if we have a fever, but we stay at home and we stay in our room for 14 days, the possibility of us transmitting that to the 2.3 or the 2.5 persons out there lessens.
Of course.
So that's the science behind social distancing. That's the science behind flattening the curve. And so our numbers will probably still be small, our official numbers, and we may never know. And the U.S. numbers are not real either. The U.S. has a backlog of thousands and thousands of tests that they cannot process. And so I think our message has got to be, let's be responsible. Let us all look at our actions. Our decision at Medical Associates was in no way intended to shirk our responsibility. On the contrary, we are being honest. We're looking out for the benefit of the patients and the population we serve, and for our staff.
All right.
You know, and this actually showed a weakness that we have in our plan floor plan. I was telling Dr. Vic for the future we need to
Yeah.
build now, taking that into our consideration. Yeah, that we have,
Separate
we
here.
integrate it, but at the same time, at any point we can separate it, you
Yeah,
know.
Well, this is our first pandemic, but we are seeing more frequently epidemics and new illnesses
Yeah, we had
being
Ebola
We had
a few
Ebola.
years ago,
Yeah.
and for Ebola we developed
H1N1.
Yeah.
Zika,
We had Zika before that,
chikungunya.
chikungunya,
Wow.
H1N1.
Yeah.
SARS and MERS didn't come all the way this
No.
way, but it was out there.
So as a country, we need to be better prepared.
Yeah.
But of course.
Thank
And
you
I would
very
think not only for us in the public sector, but also the private sector has to invest more in that area of infectious diseases and,
Definitely.
and be ready,
Yeah.
you know.
Be ready for
So
anything.
we
at
won't
any time.
have hurricane plans. Now we have tsunami plans, and now we'll have to have pandemic plans
Yep.
as well.
Yeah.
And this is our first experience. So thank you for coming in
Thank
and
you.
explaining your decision. It sounds like it was a tough one, but nonetheless, we can appreciate the honesty.
Thanks very much for
Thanks,
inviting
Marlene.
us.
Thanks.
Also.
We're going to go ahead and take that final break, and when we come back, we'll have our wrap up. So stay tuned.